Thank you, professors. Good morning, professors. I'm privileged and very honored to be the presenter of the conference. I'm going to talk about single-stage revision with direct intra-articular antibiotic infusion for culture-negative PGI. No special disclosure. This may be your face when you see my title. Sounds so crazy, huh? Please calm down and let me introduce. The reason that we call periprosthetic joint infection or disaster complication is much more than this video. Culture-positive results play a decisive role in the management of PGI. Most of the time, this is what we want. Actually, we have 30% chance to get these culture-negative results due to these reasons. This may be our frustrating phase when facing this embarrassing situation because uncertainty that surrounds the diagnosis and the optimal choice of treatment strategy. Culture-negative PGI is considered a contraindication of single-stage revision, since Professor Baochao study published in 1981. Although surgical techniques and antibiotic usage have made significant progress during the past 30 years, and the conservative opinion still be held by most orthoplastic surgeons, we have performed single-stage revision for over 20 years and in over 95% of our chronic PGIs. So we retrospectively reviewed our data and report the infection control rates by using this technique. 243 chronic PGI were divided into two groups based on culture results. In patients with negative cultures, PGI with diagnosis based on other criteria except those involving culture results. We have divided our technique into three stages. First, after aggressive debridement, the surgical area was exhaustively irrigated with a large volume of saline hydrogen peroxide and was soaked in betadine. Second, intermission. Third, we poured vancomycin plunger into the femoral and the tibia or the bottom of the acetabulum and implant a new prosthesis. Hepatic and kidney function were monitored during whole perioperative time. For the culture-negative PGI, 500 milligram vancomycin received intravenously every 12 hours for an average 14 days. Besides that, just as picture showed, we use the three-branch catheter approximately for intra-articular antibiotic infusion. For the knee, we just do the direct injection. In this way, imipenem and vancomycin alternately used in the morning and afternoon respectively. After patient discharge, levofloxacin and rifampicin combination were recommended for general use as oral switch therapy for 1 to 3 months. And the mean follow-up period of both two groups were more than 50 months. At the last follow-up, 90% of patients got satisfactory outcome and no recurrence of infection in culture-negative group, which was similar to the culture-positive ones. And the limited study are all related to two-stage revision, and since the culture-negative PGI is considered a contraindication of single-stage revision, even so, the outcome of this study are variable and no consistent antibiotic regimens are provided. In our opinion, whether single-stage or two-stage revision, the culture-negative PGI, the key point in the management of culture-negative PGI is to use antibiotic adequately and reasonably. We have two crucial antibiotic strategies. First, vancomycin and imipenem were combined together, which is the broadest spectrum plan covering gram-negative and gram-positive bacteria. And given the varying prognosis of multi-resistant organisms and increasing number of positive bacteria, vancomycin was recommended as the first agent for the culture-negative PGI. At the same time, we all know it would increase the risk of systematic toxicity to infected patients if vancomycin and imipenem are both used intravenously. So we use these two weapons locally. Obviously, that's one of the advantages by the intra-articular antibiotic infusion. And second, local application of antibiotics. PGI without bone film presents a lot of clinical challenges. And according to the study of Professor Whiteside, this technique could provide extremely high antibiotic concentrations in the thin fluid. We admit that we're crazy, but we still have our own rules. The contraindication in our center, the infection joint function cannot be reconstructed by irreversible operation, or infection widely spread to other cavities, or involving neurovascular bundles, or severely immunocompromised patients with active immune system infection or cannot tolerate any surgery. Conclusions. Our data suggests that the commonly held belief that a culture-negative PGI is one of contraindication of single-stage revision may need to be reconsidered. Steve Jobs said, who are crazy enough to think they can change the world, otherwise could do. We already started with very, very small step forward. Do you see the sunlight behind the dark clouds? We see that. Thank you.
Thank you. So any questions from the floor? Yes. Those.
Congratulations. Great talk, of course. I'm
Thank you, sir.
always a fighter for the one stage, but I would have some concerns in your treatment pathway. To rely only on vancomycin and imipenem has a lot of disadvantages. In our opinion, you have to tailor your antibiotic therapy to the susceptibility of the germ. If you don't do it, you're becoming a very high risk to develop resistances. In Europe, there are some areas where the resistance against imipenem in the meantime, and imipenem as one of our last weapons, is 70%. Against vancomycin, in some countries, it's already also 60 to 70%. So do be aware a little bit about this if you do this very brave kind of surgery.
Thank you, sir.
Thanks very much, Baochao.
Thank you.